versus ceftriaxone when looking at synergy in Enterococcus faecalis endocarditis. So my objectives are to define and explain antibiotic synergy in E. faecalis endocarditis, summarize guideline recommendations, and then discuss some literature comparing the use of gentamicin versus ceftriaxone for synergy. For a little bit of background, endocarditis is a rare but potentially lethal infection when there are bacterial vegetations in the heart. It's the fourth most life-threatening infection following sepsis, pneumonia, and intra-abdominal infections. And then there's three big organisms that can cause endocarditis, which are Staph aureus, Streptococcus, and Enterococcus faecalis. And Enterococcus is going to be accounting for about 10 to 14% of cases. So on to objective number 1, describing synergy. So by definition, it's when the killing of two antibiotics together exceeds the sum of each individual agent's killing. And then if you're kind of looking at time kill curves, as you can see on the slide here, another definition would be a decrease greater than 2 logs per CFU after 24 hours when using the drug combination. So synergistic combinations are beneficial because they can lead to a bactericidal effect rather than the individual drugs being bacteriostatic, which is particularly beneficial in endocarditis because we want to reduce any risk for spread of the infection. So the first synergistic combination would be ampicillin or penicillin or vancomycin plus gentamicin. So the mechanism here is that the cell wall agent facilitates the uptake of the aminoglycoside. So that allows it to enter and exhibit its bactericidal effect. This little football reference on the slide kind of provides another way of looking at it, and that it like breaks down. I'm not very good with football references, so sorry if I use the wrong terminology here, but if it breaks down like the wall of linemen, the running back can enter the cell and do whatever he needs to do in there. Gentamicin dosing is going to be 1 mg per kg, and you can do therapeutic drug monitoring to determine a patient-specific pharmacokinetic regimen to maximize that. And then concerns with gentamicin, as you're all likely aware, are going to be nephrotoxicity, ototoxicity, vestibular toxicity. And there's also concern for high-level aminoglycoside resistance. So now looking at ampicillin and Ceftri, the mechanism here is going to be different. This is the ampicillin and the Ceftri are going to be binding to different penicillin binding proteins that E. faecalis expresses, which then leads to saturation of those binding proteins. So the bacteria can't make its cell wall, causing a bactericidal effect. Dosing was going to be 2 grams every 12 hours, and this is going to be done for the full 6 weeks of therapy for endocarditis. Some considerations with Ceftri, you're not as concerned with nephrotoxicity, ototoxicity, or vestibular. There is some concern for VRE colonization in the GI tract, and C. diff is, of course, a concern as well. So onto guideline recommendations. The guidelines don't really make strong preferences one way or another. They say it's a 2A and B level recommendation for patients with penicillin susceptible enterococcal endocarditis. You could use AMP or penicillin plus Gent or AMP plus Ceftri. And they say when Gent is not an option, that it's reasonable to use double beta lactam, being AMP and Ceftri. And then if there is aminoglycoside resistant strains, that you should be using ampicillin plus ceftriaxone. And then onto the evidence. So this first study is from 2013, and the purpose was to compare the safety and efficacy of ampicillin and ceftriaxone to ampicillin and gentamicin for Enterococcus faecalis endocarditis. And this was kind of the first study really comparing the two, because prior to this it was just AMP and Gent had more evidence, and that was kind of what was being used more often. So this was an observational, non-randomized, multi-center study, and they compared ampicillin plus Ceftri versus ampicillin plus Gent with patients having at least 2 weeks of gentamicin. And in terms of statistically significant outcomes, there were 9% adverse effects in the ampicillin Ceftriaxone group versus 44% in the AmpGent group. And then there was also a statistically significant increase in adverse effects requiring treatment withdrawal. So more patients had to discontinue treatment or switch treatment when they were started on AmpGent. And then treatment stopped due to new renal failure. This was seen much more in AmpGent group, and there was none in the AmpCeftriaxone group. There, however, was not any statistically significant difference in death during treatment, 90-day mortality, treatment failure, relapse, or complications. So patients in the AmpCeftriaxone group did have a higher amount of the baseline characteristics that would kind of exclude them from using gentamicin, such as chronic renal failure, and then some other higher risk characteristics. But this article concluded that in patients with Enterococcus faecalis endocarditis, treatment with ampicillin Ceftriaxone does have similar therapeutic outcomes as gentamicin, and that treatment with ampicillin and ceftriaxone can be used without concern for renal failure. So this brings us to this next study, which was done in 2021, and they were wanting to really evaluate mortality data as their primary outcome when using ceftriaxone as an alternative to gentamicin for synergy. This was a propensity-matched multicenter retrospective analysis. And the primary outcome, as I said, was all-cause 90-day mortality, which had no statistically significant difference amongst the two groups. And then looking at adverse effects, you could see higher amount of AKI in the ampicillin gentamicin group, and then higher amount of ototoxicity, but there was a higher amount of C. diff infection in the AmpCeftriaxone group. Some other outcomes was looking at switches in therapy, bacteremia, relapse, and estimated duration of bacteremia. So there was a much higher amount of patients in the gentamicin group that were switching therapy, which is important to note when looking at outcomes in endocarditis. So this study concluded that therapy with AMP and Ceftriaxone had no difference in mortality, treatment failure, or bacteremia relapse when comparing to AMP gentamicin when looking at propensity matching. So these two studies brings us to this meta-analysis, which has 4 studies, 2 of which are the ones we just talked about, and the other 2 were smaller single-center studies, so I chose not to individually highlight those 2. And this one was a 2021 meta-analysis that was done to investigate if ampicillin and Ceftriaxone was non-inferior to AMP and gentamicin, including 4 studies, a total of 599 patients. And you can see that looking at these odds ratios, they all point towards favoring ceftriaxone as the option for synergy. And looking at like in-hospital mortality, nephrotoxicity, and adverse effects, all statistically significant for, the in-hospital mortality was not statistically significant amongst the 2 groups, and then nephrotoxicity and adverse effects requiring withdrawal were statistically significant, favoring ceftriaxone. So in conclusion, this study stated that treatment with AmpCeftriaxone is non-inferior, associated with less nephrotoxicity and less drug withdrawal when compared to AMP and gentamicin. So in summary, ampicillin and ceftriaxone are equally as effective as ampicillin and gentamicin for infective endocarditis due to Enterococcus faecalis, and that there is no mortality benefit when using AMP gentamicin over AmpCeftriaxone. And then finally, that ceftriaxone is going to be a safer option than gentamicin for synergy, and patients can tolerate ceftriaxone for longer periods of time. And here are my references. And if anyone has any questions,